Kirana, and
apologize for the signal. Maybe Dr. Ari losing the signal.
Okay. I'm sorry. Apologies for this technical problem. And good afternoon again from for the Kyoto Prefectural University of Medicine and all of the staff, and also for our consultant here, Professor, Medical Staff Doctor from RSGM, as well as the residents, fellow, and all the colleagues who attend this afternoon webinar. And greeting from Jakarta, and I hope everyone is good health both in Japan and Indonesia. And it's my great pleasure to welcome you again on this Bimonthly resident case presentation. Currently has been going through the third years, as I mentioned, Dr. Aditya, and I think we are very grateful for this webinar. And I think we can see that the impact of this program is very rewarding. And many of us, I think, including the resident, also the consultant, has been taken the benefit of this webinar session, and that can be implemented either in the clinic or academic purpose. But today I'd like to also share some good news that the MOU that we have been proposed, since maybe last year, now it's been granted by our rector of the University of Indonesia, and currently are being sent, I think, to Kyoto University for signing. So with this MOU, I think the collaboration between these two institutions can be further developed, that including maybe in the future resident exchange program and also collaborative research. And I think, of course, this is very valuable opportunity, especially for us here, to be able to collaborate with the institution that is well known and prestigious, and can be so eventually that can be improve the quality of service, especially here in Jakarta, and with ultimately be useful for the community as well. So I'm sure that our colleagues here will be makes us the collaboration for the advancement of our institution. So again, I'd like to thanks again for the support from Kyoto Prefectural Hospital, especially from Dr. Professor Chi Sotosono. So with this MOU, hopefully we can talk even further about the collaboration in the future. And in this September, I think we're gonna host the Corneal session here in Jakarta. Hopefully we can see each other, and we like to invite you for to our hospital, and we can talk about more about this MOU collaboration as well. So I think congratulations for both of us, for this MOU. Hopefully we can get the benefit, I mean, for the collaboration between the Kyoto and our Cipto Mangunkusumo Hospital. So I think without further ado, we will have a session today with the Corneal division, about this case presentation that will be given by our resident, and also there's a lecture as well from the consultant. Okay, I think that's it for me, and hopefully I wish you all attendees to have a good time for the webinar session. Thank you.
Thank you, Dr. Ari, for your warm welcome. So we'll proceed for the next stage from Professor Chi Sotosono. That will be proceed. The time is yours.
Thank you, Yuria, and thank you very much for Professor Ari and all staffs in the University of Indonesia. Can you hear my?
Oh, yes, we can hear clearly.
Okay. Thank you very much. And in February, our team, almost 10 members, visited Jakarta, and I want to appreciate all of the members of Indonesia University, so welcoming us, and we had a very good time in Indonesia in February. Thank you very much. And this is the first seminar in the series of our joint web seminar. And the purpose of this joint seminar is to learn Osamu each other and to know to deepen our friendship between KPUM and Indonesia University. And the MOU, thank you very much for the processing of MOU between two universities. And today I contacted with the International Center of KPUM, and the MOU is the final steps, and we can send the sign of president in near future. Thank you very much. And in this year, we have the 12 new members in our department, and new members also join in this joint seminar for the first time. And so I would like to, and we would like to enjoy and learn from this seminar. Thank you very much.
Thank you very much for your speech, Professor Sotozono. Yes, we are also looking forward for the discussion today. So without further ado, I would like to invite the first presenter from Universitas Indonesia, Dr. Anya Dewi Nastiti. She will present with the title Ultrathine Defect in Glaucoma Eye. So Dr. Anya, you may proceed with your presentation.
Okay, thank you, Dr. Yulia Aziza. Let me share my screen. Okay.
Dr. Anya is the third year of a resident in our program. She's now after her rotation on corneal cataract and refractive surgery division. Yes, please, Dr. Anya.
Okay, thank you, Dr. Yulia Aziza. Good afternoon, professors, doctors, and all participants. Thank you all for being here. My name is Anya, third stage resident. And today I would like to present some cases from cornea cataract and refractive surgery division with the title of ultra-thin decimet stripping endothelial keratoplasty or DESEC in glaucoma eye. So this is the first case illustration. So the patient was female, 64 years old, came to our outpatient clinic with the chief complaint of blurry on the left eye since 3 years before admission. And the left eye was only sensitive to light since 3 years ago, and the right eye was total vision loss since 10 years ago. The patient has a history of glaucoma since 15 years ago and underwent glaucoma implant surgery on the left eye in 2021. And then she also underwent cataract surgery on the left eye in 2021 and has a history of eye syndrome on her left eye. And this is the ophthalmological status on her initial visit. The visual acuity was hand movement with good IOP, and the cornea was hazy with cicatrix on all cornea with descemet fold, but we did not found any bullae. And the anterior chamber was shallow, and we found there was a tube on 1 o'clock position, and the iris and pupil was irregular, and the lens was IOL. So this is the anterior segment OCT of her left eye on the first visit. And we can see here that the central thickness, it was 1,010 millimeters. Okay, so we assess this patient with pseudophakic bullous keratopathy of the left eye with eye syndrome and secondary glaucoma of the left eye with post-Virna glaucoma implant and non-functional eye of the right eye. So we plan to do DESEC and pupilloplasty of the left eye in general anesthesia, and we also gave glaucoma medications to the patients. So this is the operation day. The patient underwent surgery on May 8th, 2004 in Kirana OT, and the donor was from Nepal with endothelial cell count was 2,320 millimeters square, and the coefficient of variations was 38 and the hex was 53. And after the surgery, we gave levofloxacin and prednisolone acetate eye drop per hour and methylprednisolone orally. And we also put bandage contact lens to improve the healing process of the ocular surface. So this is the post-operative follow-ups. As we can see here on her post-operation day 1, that the IOP was 13 with hazy and edema cornea, and the graft host junction was good, and it was attached and in the central, and with no cleft was seen. And the anterior chamber was deep with bubble on the superior part. The post-operation day 7, or 1 week after the surgery, the IOP was remained almost the same, and the cornea was getting more clear, but still minimal hazy with edema, and the bubble was already gone. And then we did the anterior segment OCT, and the thickness with the donor was 833. So on almost a month after the surgery, the IOP was still. The cornea was clear with no edema, and the graft host junction was still good and attached. And we performed another anterior segment OCT, and the thickness of the cornea donor was 51 micrometers. So this is the ultra thin dissect, and I will explain about it later. Moving on to the second case illustration. So our second patient was a male, 20 years old, that was referred from glaucoma division with blurry on his left eye since 14 years ago. So he was diagnosed with juvenile glaucoma when he was 6 years old and underwent glaucoma implant surgery on his right eye on 2016, and left eye with 2 times of glaucoma implant surgery in 2014 and 2022. And the right eye was total vision loss since almost a year ago. This is the ophthalmological status on his initial visit. The visual acuity was 0.5/60, and the IOP was high. It was 27, and the patient already used latanoprost and timolol eye drops. And the cornea was hazy and edema. And then the anterior chamber was still deep, and the iris and pupil was dilated with no light reflex. So we assessed this patient with juvenile glaucoma and corneal endothelial decompensation of the left eye, with the phakic of the left eye and non-functional eye of the right eye. So we also plan to do a dissect and pupilloplasty of the left eye in general anesthesia, and we also gave glaucoma medications. So this is the operation day. The patient underwent the surgery last year on October 3rd, 2023, and the donor was from USA. And after the surgery, we gave levofloxacin and prednisolone acetate eye drop per hour and methylprednisolone orally. So this was the video of the surgery of the patient that was done by Dr. Rhendy in Kirana OT. So first, we did the scraping for better visualization and trying to see the iris tissue to make sure that if it's possible to do the pupilloplasty or not. But we found that the iris was very fragile, so we decided not to do the pupilloplasty. So we proceed to do the scleral tunnel length about 5 to 7 millimeters, 2 millimeters from limbus. And then we dyed the endothel and put 8.5 millimeters mark on cornea. And then we did descemethoraxis, followed by cleaning the OVD in the anterior chamber. Okay, and then we prepared the graft mounted to the artificial chamber and with 350 guarded knife, made peripheral grooving, and then continued with lamellar dissection using crescent knife. So we dissected the donor manually with lamellar dissector all the way to peripher and cut the cap. And then we redid the dissection with crescent knife, approximately 100 micron thick, and followed by lamellar dissection. And we detached the graft from the artificial chamber carefully and placed the graft and cut circumferentially with 8.0 Baron Trifine. And then we put the dispersive OVD on the scleral tunnel and placed the graft with the endothelial facing down. And then we sit with cystotome, we bring the graft inside the eye using push-through technique. And we put some bubble under the graft and sutured the tunnel using 10.0 nylon. And because the patient had glaucoma implant tube before, so we decided to put one anchoring suture at the superior part at the superior part of the graft to facilitate graft attachment. And then we put antibiotics intracapillary, and we concluded the surgery. Okay, so this is the post-operative follow-ups. On 1 week after the surgery, the IOP was 11, and the cornea was still hazy and edema, and the graft host junction was good and attached in the central with no cleft, and the anterior chamber was deep. 3 months after the surgery, the cornea was clear with good IOP and deep anterior chamber, and here from the anterior segment OCT, the central corneal thickness was 735 and 35, and the thickness of the donor was 131. And these are the other similar cases that we found in our outpatient clinic. This is the patient A who underwent dissect, and the cornea was getting more clear after 8 months. And then this is the patient B, the pre-op and post-op in 3 months. And this is the patient C, D, E, and F. This is the follow-ups ranging from 1 until 6 months of follow-ups. And we see here that the cornea is getting more clear after the dissect surgery. Moving on to the discussion. So the cornea is a clear front window of the eye, as we already know, and made of layers of cells. And if it scared, swollen, or damaged, the light is not focused properly into the eye. And there are different types of corneal transplants. And in some cases, only the front and middle layers of the cornea are replaced. But in other cases, maybe only the inner layer is removed. And sometimes the entire cornea needs to be replaced. And this is the schematic diagram of penetrating keratoplasty and the current endothelial keratoplasty techniques. We know that there's penetrating keratoplasty, a full thickness transplant, and then DALK or deep anterior lamellar keratoplasty, and then dissect, that we will talk about this later, and DMEK. So decimal stripping endothelial keratoplasty or dissect was first introduced in 2002 by Mels et al. And that facilitated selective method or stripping of the host diseased corneal descent membrane. And another technique using automated microkeratome that enabled standardized dissection of a donor posterior lamella, and it was called decimal stripping automated endothelial keratoplasty. And then various donor graft thickness are available and fall into the 4 general categories. Nano-thin decimal stripping automated endothelial keratoplasty, ranging about 15 to 49 micrometers, and then ultra-thin dissect, around 50 to 99 micromillimeters, and thin dissect, and conventional dissect. And ultra-thin dissect or UT dissect, it is a new form of endothelial keratoplasty with donor graft approximately 50 to 99 thick, and then it was superior visual acuity outcomes compared to the traditional dissect procedure. So what is the comparison between dissect and DMEK? A study by Jensen et al. In 2021 stated that the DMEK patients had better BCVA than dissect patients. And the MEK has higher rebubbling rate. But in learning curve, no evidence for both techniques. Additional studies have shown 2020 visual acuity rates in DMEK is 25% at 3 months and 48% at 6 months. And this was further DMEK's promising visual acuity advantage. And dissect may be associated with less visual improvement due to astigmatism from a larger incision, subepithelial haze, and hyperopic shift caused by transplanted stroma between the donor and host corneal curvatures in thicker graft. As newer ultra-thin methods are developing, which is the UT dissect, which have shown 2020 performance in 12.3% of patients after 3 months and 26.3% after 6 months. So the visual acuity gap between the two procedures may be closing. This is the comparisons between PKP, DMAC, standard dissect, and thin dissect. We can see here the differences between the graft thickness, as the PKP is really thick, around 550, and then the thin dissect is less than 150. And then the graft handling difficulties, here we see that the DMAC has more difficult than the other procedures. And the healing time for PKP and DMAC is faster than the other, but the thin dissect is faster than the standard dissect. And then the survival rate is high for other techniques. So the UT dissect in glaucoma patients are more challenging because in glaucoma patients, they have shallow anterior chambers, so it was hard to insert the graft and to maintain the bubble after the surgery. And history of multiple glaucoma surgeries, including glaucoma implant or trabeculectomy. This will be difficult in air management during transplantation. And several tips can facilitate endothelial keratoplasty in eyes with tubes. And prior to surgery, one has to evaluate the tube in the anterior chamber. And if the tube is oriented towards the cornea, then it needs to be repositioned, and we can cut the tube into round edges. And then air management also difficult in fixed dilated pupil. And the procedure, the UT dissect, will increase the risk of glaucoma. This would be the end of my presentation. Thank you so much for listening.
Thank you, Dr. Anya, for the nice presentation. So before we proceed for the discussion, we will move to the next presenter. I would like to invite Dr. Shuhei Yonebayashi from the Kyoto Prefectural University of Medicine. He will talk about the electrolytic removal of granular corneal dystrophy after LASIK. So, Dr. Yonebayashi, your time is yours.
ミュートになってます。ミュートに。
Dr. Yonebayashi is the first year president of the KPWEN, so he will do the presentation for the first time in our section.
So, Selamat malam, namaku Yonebayashi. So, thank you very much for this opportunity to make this presentation. I'm Shuhei Yonebayashi, Department of Ophthalmology, Kyoto Prefectural University of Medicine. Today, we present electrolytic removal of granular corneal dystrophy after LASIK. So, first, case report. The patient is a 44-year-old female who had LASIK surgery performed on both eyes 12 years ago. 1 year later, she had photophobia and was diagnosed with granular corneal dystrophy type 2. She was followed up, but the clouding gradually became more severe and interfered with her daily life. So she was referred to our department for surgery. Eyesight and IOP is as shown. So let me share photos. So what is this? So at first, let me explain what LASIK surgery is. LASIK is one of the most common refractive correction surgeries. As shown in the diagram, a thin flap is created on the surface of the cornea to expose the cornea stroma. The excimer laser is used to remove the cornea stroma until the correct thickness is achieved, and the procedure is completed by replacing the flap. The previous case was granular corneal dystrophy type 2 exacerbation after LASIK. Granular corneal dystrophy type 2 is an autosomal dominant corneal dystrophy caused by missense mutations in the TGF-beta1 gene. The estimated prevalence in East Asia is around 0.25%. LASIK surgery worsens the interlaminar opacity as shown in the previous picture. Granular corneal dystrophy is often not apparent at young age and often leads to this condition following LASIK surgery. In this case, corneal electrolysis was performed on both sides. The procedure was performed on the left eye and 6 months later on the right eye. So let me share the movie. So we are peeling off the flap very carefully. To 10 times. And wash out. And 5 volts, 3 seconds again. And finally, check and finish. So in the past, PTK was used to remove interlaminar opacity, but there was a disadvantage of changing the refraction. Refractive error is corrected by LASIK, and the refractive error should not be changed as much as possible. Corneal electrolysis is attracting attention as a new treatment option. This treatment has virtually no change in refractive index and almost no post-operative recurrence. So let me share progress of the left eye. So comparison before and after corneal electrolysis improved corneal transparency. As indicated, vision remains the same after surgery with hyperoptic shift. The subsequent progress is shared. In this case, there was a recurrence of corneal opacity in the central area 1 year later. So, corrected visual acuity improved to 1.0 in about 3 months and lasted for about 1 year. But has deteriorated slightly with recurrence of corneal opacity. The reflection is 0 plus 0.5D as it was preoperativity. Let me share the cornea shape. As shown, there was no significant change in postoperative cornea shape. So let me share about eye drops. After surgery, corneal epithelial damage was observed. So levofloxacin and betamethasone were used for about 1 week. Then betamethasone was replaced by fluorometron, and the frequency was gradually tapered off. At 6 months, corneal epithelial damage was observed, and levofloxacin and fluorometron were restarted, and ofloxacin ointment was added. 1 year later, a recurrence of central corneal opacity was observed, so tranilast ophthalmic solution, which reduced inflammation, was added, but there was no improvement, so fluorometron and oxaloxacin ointment were added as needed until now. She is now considering whether to try PTK or corneal electrolysis again in the future. And let me share the progress of the right eye. So comparison before and after surgery, corneal transparency has improved. Subsequently, the transparency of the cornea has generally been maintained. Visual acuity improves to around 1.0 with a slight deterioration thereafter. The reflection is almost no change. So share about the shape of the cornea. Immediately after surgery, there was edema of the cornea, but it gradually improved and 1 year has passed and there is not much change from the preoperative state. And let me share about eye drops. Immediately after surgery, there was an extensive epithelial defect. First, levofloxacin and betamethasone eye drops were administered, and after a week, the betamethasone was changed to fluorometron. The therapeutic soft contact lens was removed, and ofloxacin ointment added once before sleep. Epithelial damage gradually improved, and after 3 months, levofloxacin and fluorometron were discontinued. 6 months later, there was a slight recurrence of corneal opacity. So a tranilast ophthalmic solution was added and then changed to fluorometron. So take-home message. Corneal electrolysis is a procedure that can remove lesions in the shallow layers of the cornea with little or no change in refraction on cornea shape. Post-operative vision is good, but may recur within 1 to 2 years. So further research is needed to prevent recurrence and whether corneal electrolysis can be performed more than once. Thank you for your kind listening.
Okay, thank you for your very interesting cases for the to be presented, Dr. Yonebayashi. So we will move to the discussion from the panelists. So I would like to invite the panelists from Universitas Indonesia, Dr. Syska, Dr. Jessica, Dr. Rio, and maybe Dr. Farabi could not attend the meeting because he will go to the Saudi Arabia for the Haji. So the panelists, would you mind to give the comment for the case presented by the resident from the KPUN? Dr. Rio, maybe, please. Yeah.
Yes, Dr. Yulia Aziza. Can you hear my voice? Yes. Okay. This is a case with the glaucoma case. Yeah, patient came with the problem. Sometimes patient with the glaucoma already done many kind of surgeries, trabeculectomy, implant, and also cataract surgery sometimes also can be done in glaucoma patient. And afterward, the endothelium sometimes can be damaged because a lot of surgery inside the eyes. So, to preserve to rehabilitation the vision, so we think to have to make the cornea become clear again. So the treatment for this case, sometimes we can do like PK for this patient, but in glaucoma eyes, it's very difficult to do PK because the chamber is shallow and also because the high chance of, because we make a like an open sky surgery, so the chance of like suprachoroidal hemorrhage is very high in this patient. So, and also in
Dr. Rio, sorry, may I cut your thought first? So
Yes,
would you
yes.
mind to give comments first for the case from the KPUN and then
Oh yeah.
explain about the case
Agree.
from
Yes.
our university?
Yes.
Yeah, please.
Thank you. Agi, yeah, this is very interesting case from KPUM. Yeah, I just read some cases about the electrolysis, but is there any can we like a modified like instrument to do like this case of surgery, and also can we do the surgery if a patient already done like LASIK patient came with the granular dystrophy, can we do directly with this technique? Because we found not too much case in our hospital about granular dystrophy, but sometimes we found the case. What we are doing here just do like a scraping, because we found like a deposit already of the superficial part, so we just do scraping using a diamond burr, and we remove some part of the deposit. And yeah, sometimes it's good, but if the depth is already, the deposit already in the central part of the stroba, sometimes we just leave it there. And the other technique we can do in here just like a DAC or PK. So my question is, can we do this technique for with like for the virgin eyes, not for the phospholastic eyes, or we have to do like a move, make a cut of the epithelial and do like this technique, or others? Thank you.
I'm sorry, I can't understand what you mean. Your question is first realistic to the cranial cornea patient?
Yes, can we do this technique for virgin eye, not for phospholastic patient?
Yeah.
This
technique is only remove the surface of the cornea only. So not recurrence cases. Cranial cornea dystrophy is surface and deep stromal opacity. So we didn't do the not risk patient to the this technique, but homozygous cranial cornea dystrophy is many times recurrence after PTK or PK.
Yes.
So this technique is using in Japan older age to treat homozygous cranial cornea dystrophy.
Okay, but what is the standard procedure that you have done in your hospital for a case like this one? You do like a DALC, or directly you do like electrolysis of the cornea?
PTK, phototherapeutic keratectomy.
Oh, okay.
The first standard therapy.
Therapy. But you will go to PK or DALC when you
cranial cornea dystrophy didn't do the PK or DALC. That become a big astigmatism and refractive error.
Oh, okay. Oh, okay, you do just like just only like a PTK and also electrolysis, corneal electrolysis for this kind of dystrophy.
Very dense opacity in the mesostroma, maybe do a PK.
Oh, okay. Yeah. Okay, but can we do like just if like a just can scrape the epithelial layer with the crescent knife and do electrolysis? It can be done like that.
Epithelial remove and electrolysis in another cases.
Oh, okay.
Electrolysis remove.
Okay, nice. Thank you very much, Dr. Osamu-san. Thank you, Dr. Aziza. Maybe the others want to ask something.
Thank you, Dr. Rio. Yeah. So the standard procedure is performing the PTK for the new case of the granular dystrophy, but in some case, you can remove the epithelial and do the electrolysis, and then if it's recurrent, you can proceed with the PTK. So is it right, Dr. Hieda?
Yes.
Yeah. So maybe Dr. Jessica would like to give comment.
Yes. So I think it's very interesting about the case from the KPUM to use the electrolysis. I personally haven't had any experience about that. But so your first priority is to use this kind of methods. So there will be no refractive change, right?
Yes.
So even so, like you said earlier, if it's in the virgin eye, you don't do the scraping and do the electrolysis. Instead, you just pick PTK.
Yes, PTK.
Is it right?
Yes. PTK is the first choice for the granular corneal dystrophy without tracing. In rich patient, opacity is
I think it's
worse in lamella. So a PTK is have to bend and flap back. So a big hyperopic shift is begun for the rich patient. So we use electrolysis.
okay.
Okay.
Do you have you had any experience about the risk of any complication while doing the electrolysis in the stroma part and then in the flap part? Because I think is there any risk of complication while doing that?
Complication is rare, but epithelial defect is almost cases occur after surgery, and recurrence is maybe slightly faster than PTK. Is a major problem.
Yes, I think it's very interesting.
Yeah. I have one question. Can we done in other case for stromal dystrophy like macular dystrophy or lattice dystrophy for this case? Is possible?
No. In Japan, this granular corneal dystrophy type 2 and rice backwards corneal dystrophy are reported to use this method, but another TGFBI dystrophy, I don't know which method is effective or not.
Okay. Yes.
Okay, thank you for the comment. So maybe we would like to invite Dr. Hieda to give comments for the residents from Indonesia. Do you have any question and comment?
Indonesia's resident, yes, this is very beautiful surgery and prepares manual prepares ultrasound is very beautiful surgery, but I wonder the incision is very big, and why don't you use a bushing glide or a pull-in technique to do a dissect? Why?
Yes, thank you for the question. Yeah, maybe Dr. Anya would like to give answer, or Dr. Yu, please.
Maybe I can. Yeah. Okay. So the question is why not using busin, yeah, for this case. Yeah, actually we have busin busin instrument for this kind of surgery, but when I learned, I've done fellowship in India, so they're using like this technique. So I just try using also busin, but it's for me it's a little bit difficult because we have to maintain the chamber with the artificial chamber. So we have to remove the chamber maintainer after we put the graft inside the IC. But I try with this push-through technique I saw. So from the meeting, SES meeting, like Indian surgery, they do like just push-through technique, bring the donor inside the eye, and with the in such way. So I found this is the like easiest technique for me. So yeah, but mostly in like a Singapore Donalton also, Professor Donalton, he did also with the busin. But because my background is I study in India, they mostly do like a posture technique. So I just followed my fellowship before. Yeah. Yes. Thank you.
Okay, thank you. Is there any question from the other participants? Maybe Prof. Supojono or Dr. Hieda? Other question? So maybe I would like to ask Dr. Rio, if you do the manual dissect like this kind of case, so what kind of difficulty that you faced mostly during the dissection?
Yeah, the same with using like automated, yeah. We do not know the depth of the second cut, because if the first cut we can do like see in using Moria instrument. So if you want to cut the cap of the donor, so we have to count also. So there is no it's like a custom made technique, yeah. If you do like a fast through the donor, it's just like a thin cut. If you do like a very slow movement, so it will be got sometimes it can be perforated. So we have to also like tailor-made how to do the movement during this using Moria. But here, because the one of the big problem in our hospital, we don't have Moria. That's the big problem. So because the demand of dissect is, I think is we need to do dissect in a lot of patient here. So I just try to like a manual dissect first. The difficulties is when to do the second cut. Yeah, the second cut because you know the thickness graph is 550. Already cut with the 350 micron. Got that knives, you already have 200 micron. So the second cut is you have to make sure that you only cut almost 100 microns. So this is based on only my experience. I see the cap of the first cut. I see this still thick, so I can go through the second cut with the almost 100 thickness. So using the most difficult case is you do like a first lamellar cut using a crescent knife, because you can go to pass through the decimate layer and can break. I have 2 cases I have complication with this technique. So I just leave it there and just cut the donor and put because that's on the second cut we already have thickness graph almost 150 or 180 micron. So if we have a complication while making the second cut, so we just cut the using like a 3-fine and put the donor inside the eyes. Yes, thank you, Dr.
Yes, thank you for sharing.
And
Yes, please, go ahead.
okay, can I make a short lecture over cranial corneal dystrophy? Okay.
Yes, please.
Okay.
Please,
Yes.
Do you see just right?
Yes, we can see the slide.
Okay. So give a short lecture. I will talk about the corneal electrolysis for cranial corneal dystrophy after LASIK. Cranial corneal dystrophy type 2 is the most popular dystrophy in Japan, and 90% in cranial corneal dystrophy is type 2. Type 2 is characterized by superficial ring-shaped opacity and star-shaped opacity in midstroma. This is amyloid and hyaline deposit. Cranial corneal dystrophy type 2 is classified in the International Committee for Classification of Corneal Dystrophy, IC3D. Listed is the 5th cranial corneal dystrophy for epithelial stromal TGFBI dystrophy. This is a autosomal dominant. And standard therapy for cranial corneal dystrophy is a phototherapeutic keratectomy, PTK, using excimer laser. PTK is approved in Japan in 1998 and covered by insurance in 1910. In diameter 6 millimeter diameter, average ablation depth is 100 micron, and hyperopic shift, average hyperopic shift is 1.5 diopter. This is a PTK for cranial corneal dystrophy type 2. It is difficult to see the opacity, so we use illumination and scleral scattering method to use using corneal vitreous light probe. And until the opacity is decreased, we ablate the cornea. This is maybe a 2 minutes, and eye drop is more clear as the opacity is gone, and to wear contact lens to protect cornea. This is a post-operative course of PTK for cranial corneal dystrophy. After PTK, the opacity is decreased, and until 2.5 years, opacity is not increased, but 5 year, 7.5 year, 10.5 year, opacity is increasingly. but visual acuity is not so much decreased until 10 years. This is a survival curve of non-recur rate of various disease after PTK. Recurrence is defined as opacities occurred and 2 line or more best corrected visual acuity decreased. And black lines cranial corneal dystrophy, and 50% recur in 110 months. That is 10 years. This means one PTK in 10 years remains visual acuity. But homozygous cranial corneal dystrophy is very severe disease, and that onset at age 3 and strong opacity become by age 10, and PTK or penetrating keratoplasty recurrence is very fast, and many times PTK is needed. So corneal electrolysis is also using this homozygous cranial corneal dystrophy in Japan. And KIM was first reported in 2002, exacerbate of cranial corneal dystrophy after LASIK. And PTK and deep anterolamellar keratoplasty was reported to treat this condition. Very deep opacity. It is a lamellar region. But PTK and dark make induce a refractive error. So we use the corneal electrolysis. Electrolysis is reported first Rodriguez in 1950, and cornea with saline wetted, and a special probe is attach the cornea and make electric current and make a small amount of sodium hydroxide. And this dissolves the cranial corneal opacity. This is a video. First, we flap the LASIK flap and mark corneal pupil area, and wetting a saline and lighting and push the cornea, and 5 volt current is 3 seconds, and mediate disappear the opacity. Now to treat the LASIK flap bedside, and then to treat the back of flap, and 12 times this procedure, and clear the cornea. This is a case of 44 years old male, cranial corneal dystrophy type 2. He 11 years ago received LASIK, and 5 years ago right eye received DALK, and his right eye is very clear, and the left eye is cloud, and pupil area is very hard opacity. So we use electrolyze this patient, and 6 months postoperatively, his left eye is very clear, and end-cellular density is normal. And this is a contrast sensitivity of electrolysis after 6 months. Right eye is very clear, but high astigmatism and high order aberration and contrast sensitivity is lower than electrolysis. This is a reason to do electrolysis that LASIK patient. We also do 9 patient, 11 eyes to this method, and average age is 46.8 years old, and all patient is 10 years after LASIK. This is a visual acuity course, and corneal opacity decreased in all cases, but post 1 week, best corrected visual acuity worsened because corneal edematous and slightly hazy. But 6 months, there's no haze and clear the cornea, and slowly improves visual acuity. A significant improvement was observed at the last follow-up, and best corrected visual acuity and uncorrected visual acuity. This is a spherical equivalent. Is after 1 week, slightly hyperopic shift, but after 1 week, spherical equivalent or almost same before surgery. And this is corneal thickness. And thickness is 1 week slightly swollen the cornea, but after that is almost the same corneal thickness. So this is the last slide. Electric removal of cranial corneal dystrophy after LASIK is good therapeutic method. Corneal thickness and refractive error are same as previous condition after LASIK. Best corrected visual acuity and uncorrected visual acuity improved slowly. Also, recurrent may be faster than PTQ or dark. Multiple surgery are possible because the thickness of the cornea is preserved. Thank you very much for attention.
Thank you very much for your lecture, Dr. Hieda. Yes, it's a very
Thank you.
it's a new thing for us. So thank you for sharing
Thank you.
about this kind of
Thank you very
method. Yeah. So I think before we proceed for the next question, if you want to repeat for the electrolysis, usually how long is the interval between each treatment? So if you perform first electrolysis and then how long shall we repeat for another treatment?
Recurrence case?
Yeah, for the recurrent case. Yeah.
We started 3 years ago, so there's no case of
No recurrent.
2 times. But maybe this year or next year must do re-electrolysis, maybe.
Yeah,
Thank
it is
you very
interesting, Dr. Osamu, when you put the probe to the disease area, it's directly gone, yeah. You just remove with the probe, place it on the corneal surface, and when you give the saline, BSS, and it directly disappear.
Yes, directly disappear.
Yes, it's very nice.
Okay, very nice. Yeah, very interesting.
Not
Because
bad
it's about the
stroma.
yeah. Not as deep as the trauma. Okay. We have one question from the chat. So, Dr. Michael, the third resident in our university, would like to ask about how do the surgeon address the risk of papillary block in dissect procedure for glaucoma patients, and what are the implications for post-operative care? Maybe Dr. Yu want to answer the question.
Yeah, thank you, Dr. Michael. Yeah, so the thing is, when we are doing idiopathic keratoplasty, we put bubble inside the eyes. In our institution, we do put bubble inside the eyes and make a inferior PI, inferior PI, so it will prevent the chance of papillary block. We'll put the full bubble inside the eye, but sometimes we can do reducing the number of bubble inside the eye, so the bubble is not not so big, so it's still place for the like aqueous to pass through the pupillary area. But mostly we done with the making a inferior PI to prevent the pupillary block. Yeah, thank you, Doctor.
Any additional comment from Dr. Hieda or other doctor from KPUM who perform the defect? Any suggestions for that kind of question? Yeah, okay, that's okay. Yeah, thank you. So it's about the time because it's already 6 p.m. here and maybe 8 p.m. at the Kyoto now. Thank you very much for the presenter and also for all the panelists and the participants. Now we are reaching 90 participants today, so very good for the beginning of our second meeting. So looking forward for the next meeting. So we will have the next meeting on July 10 with the uveitis case topic. So maybe we from our university would like to present about the tuberculosis cases about the uveitis. So the next meeting will be on July. Before we close the meeting, would you mind to open your camera and put a big smile on your we want your student to have taken the picture. Dr. Anya, maybe help, would you mind?
Okay.
Yeah, thank you.
Okay, I will take the picture now. 1, 2, 3. Okay. Okay, then.
Okay, then, yeah, thank you very much. So have a good rest of your day. Thank you for listening to our meeting, and thank you, and wassalamualaikum warahmatullahi wabarakatuh. Yeah. Bye.
Thank you. Good afternoon.
Thank you very much.
Good evening. Bye.
Thank you.
Thank you very much.
Very much. Arigatou gozaimasu, sensei.